I'm Dr. Michael Hayes, board-certified gastroenterologist with 18 years of clinical experience, and I need to tell you about Harold, a 62-year-old retired postal worker from Ohio who walked into my office on a Thursday afternoon complaining about blood in his stool, and I told him we needed to run tests immediately, but he said he'd think about it, that he was busy with his grandkids visiting that weekend, that it was probably just hemorrhoids anyway, and 3 nights later, at 3:15 in the morning, his wife woke up to find him unresponsive in their bed, and by the time the paramedics arrived, Harold was gone. Before we go any further, I need to be absolutely clear. This is educational content, not personal medical advice, and if you are experiencing any of the symptoms I'm about to describe, you need to see a doctor immediately. Do not wait. Do not assume it's nothing, because what I'm about to share could save your life. Harold's death certificate listed the cause as massive gastrointestinal hemorrhage with hypovolemic shock, which is medical terminology for he bled to death internally while he slept. And when I reviewed his case with the coroner and spoke with his wife, we pieced together exactly what happened, and it involved one critical mistake that millions of people make every single day without realizing the danger. Here's what Harold's wife told me. For the past 6 months, her husband had been straining excessively during bowel movements, sometimes spending 20 to 30 minutes on the toilet, pushing hard, holding his breath, face turning red from the effort, and she'd asked him about it, worried, but he'd brushed it off saying constipation was normal at his age, that his father had dealt with the same thing. She said he'd noticed bright red blood on the toilet paper occasionally, maybe once or twice a week, small amounts, and he'd mentioned it to his primary care doctor during a routine visit 2 months before his death, and the doctor had said it was probably internal hemorrhoids, gave him some cream, told him to eat more fiber, and that was the extent of the conversation. No digital rectal exam, no referral to a gastroenterologist, no colonoscopy scheduled, just hemorrhoid cream and fiber supplements. The night Harold died, his wife remembered he'd gone to the bathroom around 11:30, right before bed, and she'd heard him straining in there, heard that distinctive grunting sound of someone bearing down hard, the sound of the Valsalva maneuver being performed over and over, and when he came out 15 minutes later, he looked exhausted, pale, slightly sweaty, but he didn't say anything was wrong, just climbed into bed and fell asleep. 4 hours later, she woke up to use the bathroom herself, and when she reached over to touch his shoulder, his skin was cold. The autopsy revealed something that makes my stomach turn every time I think about it. Harold had developed severely enlarged internal hemorrhoids, grade 4, which had been chronically bleeding for months, and on top of that, he had esophageal varices, swollen veins in his esophagus that we later determined were caused by early-stage cirrhosis from years of moderate drinking that had never been diagnosed, and that final session of extreme straining, that prolonged Valsalva maneuver where he held his breath and pushed with all his strength, created such massive pressure in his abdominal and thoracic cavities that it ruptured one of those esophageal varices, and he began bleeding internally at a rate of approximately half a liter per hour. He went to sleep feeling tired, maybe a little off, not realizing that blood was pooling in his stomach, and over the next few hours, his blood pressure dropped progressively lower, his heart rate climbed trying to compensate, and eventually his body simply couldn't maintain perfusion to his vital organs. The blood he'd seen in his stool for months wasn't just hemorrhoids. It was a warning sign of vascular fragility, a sign that his venous system was under stress, that his liver wasn't processing blood the way it should, that his body was vulnerable, and that one moment of extreme physical strain could trigger catastrophic bleeding. If this is making you think differently about bathroom habits, subscribe to this channel because I post weekly content about digestive health that could genuinely save your life. And next week, I'm covering the warning signs of liver disease that most people completely miss. Now let me explain exactly what happened inside Harold's body, because understanding this mechanism is the only way you'll take this seriously. When you sit on the toilet and bear down to have a bowel movement, you're performing what we call a Valsalva maneuver, which means you're closing your glottis, that's the opening to your windpipe, and you're contracting your abdominal muscles forcefully while holding your breath, and this action dramatically increases the pressure inside your abdomen and your chest. Normally, for a healthy bowel movement, you need only a small amount of this pressure, maybe 10 to 15 millimeters of mercury above baseline, just enough to help push stool through the final portion of your rectum and out through the anus. But when someone is constipated, when the stool is hard and difficult to pass, people instinctively push harder, they hold their breath longer, they bear down with maximum force, and the pressure inside their abdomen can spike to 80, 100, sometimes even 120 millimeters of mercury, and that pressure gets transmitted everywhere, to every blood vessel in your abdomen, your pelvis, your chest, your neck, your head. Here's what most people don't understand. You have a network of veins running through your rectum and anus called the hemorrhoidal plexus, and these veins are designed to help with continence. They cushion the anal canal, they're a normal part of your anatomy, but they're also vulnerable because they don't have valves like the veins in your legs do, which means blood can pool in them when pressure increases, and when you strain repeatedly, day after day, week after week, these veins become engorged, swollen. Eventually, they prolapse and bleed. That's how hemorrhoids form. But here's the part that killed Harold. The pressure created during straining doesn't just affect the veins in your rectum, it affects every vein in your body that doesn't have strong muscular walls to resist it. Your esophagus, the tube connecting your throat to your stomach, is lined with veins. And in someone with liver disease, even early undiagnosed liver disease like Harold had, those veins become enlarged because blood that should flow smoothly through the liver gets backed up. The pressure in the portal venous system rises and the esophageal veins swell like overfilled balloons trying to accommodate the extra volume. These are called esophageal varices, and they're fragile. The vessel walls are thin and stretched, and when you create massive pressure in your chest and abdomen by straining during a bowel movement, you can rupture them. Harold's case wasn't unique, it was predictable. He had risk factors he didn't know about. Undiagnosed cirrhosis from years of drinking 2 or 3 beers every night, which seemed harmless, which never caused jaundice or obvious symptoms, but which was slowly scarring his liver tissue and raising the pressure in his portal vein. He had chronic constipation from a low-fiber diet and not drinking enough water. He had the habit of straining forcefully because that's what his father did. That's what he thought men were supposed to do. Push through it. Don't complain. And he had bright red blood in his stool that he dismissed as hemorrhoids without ever getting properly evaluated. Each of these factors alone might not have killed him, but combined, they created a perfect storm, and the trigger was something as mundane as trying too hard to have a bowel movement. Let me tell you about the blood he was seeing, because this is crucial. Harold told his wife the blood was bright red, on the toilet paper, sometimes a few drops in the bowl, and both he and his primary care doctor assumed this meant hemorrhoids because bright red blood typically indicates bleeding from the lower GI tract, from the rectum or anus, which is often hemorrhoidal. And that's true, most of the time bright red rectal bleeding is from hemorrhoids or anal fissures, conditions that are uncomfortable but not life-threatening. But here's what they missed. The amount matters, the frequency matters, the associated symptoms matter, and the patient's overall health matters. Harold was 62 years old with a history of alcohol use, even moderate use, which should have prompted questions about liver function. He was straining excessively, which indicated chronic constipation that needed evaluation. The bleeding had been going on for months, which meant this wasn't an isolated incident. And he was feeling increasingly fatigued, which his wife mentioned to me after his death, but which he'd attributed to getting older, to not sleeping well, to stress. Comment below if you've ever seen blood in your stool and didn't seek medical attention. I want to understand how common this dangerous assumption is. What Harold and his doctor should have done was this. Any rectal bleeding, even if it seems clearly hemorrhoidal, warrants at minimum a digital rectal exam, and in someone over 50, it warrants a colonoscopy if they haven't had one recently, because we need to rule out polyps, cancer, inflammatory bowel disease, diverticulosis, and other serious conditions. If someone is straining excessively, we need to address the underlying constipation, not just hand them fiber supplements and send them home. We need to ask about diet, fluid intake, medications that might be contributing, mobility, bowel habits, and we need to examine them. If someone has any risk factors for liver disease, history of alcohol use, obesity, diabetes, viral hepatitis exposure, certain medications, we need to check liver function tests. We might need an ultrasound. We might need a fibroscan to assess for cirrhosis because early liver disease is silent. You don't turn yellow until the damage is severe. You don't retain fluid until you're in late stages, but the varices can form years before obvious symptoms appear. Here's what the autopsy showed in detail, and I'm sharing this not to be graphic, but because you need to understand the stakes. Harold's esophageal varices were grade 3, which means severely enlarged. The largest one measured about 15 millimeters in diameter, and it had ruptured at a point about 20 centimeters from his teeth, right where the esophagus meets the stomach. The bleeding had been massive, but initially slow. Blood had filled his stomach, approximately 1.2 liters according to the coroner's report, and as his stomach filled, the blood had nowhere to go initially, so it just sat there, distending his stomach, and he probably felt full, maybe nauseous, but he was asleep, so he didn't register these sensations as alarms. Eventually, his body tried to protect him. His stomach contracted to expel the blood, but instead of vomiting, which might have woken him and his wife and prompted a call to 911, the blood moved down into his small intestine, and by the time his compensatory mechanisms failed and his blood pressure dropped critically low, he'd lost so much blood volume that his brain and heart couldn't maintain function. His wife found him approximately 4 hours after the rupture occurred, and by then, there was nothing anyone could have done. The hemorrhoids were a red herring. They were real. They were there. They were probably causing some of the bleeding he'd noticed, but they weren't the lethal problem. The lethal problem was the varices he didn't know he had, caused by cirrhosis he didn't know he had, triggered by straining he thought was normal. And this is why I'm making this video, because Harold's story is not rare. Every gastroenterologist has seen cases like this. Patients who ignored warning signs, who assumed symptoms were benign, who didn't connect their bathroom habits to serious health risks, and who paid the ultimate price. Let me walk you through the signs Harold missed, the signs you need to watch for. First, rectal bleeding of any kind, any amount, any color, needs to be evaluated by a physician. Bright red blood usually indicates lower GI bleeding, hemorrhoids, fissures, sometimes polyps, or cancer in the colon or rectum. Dark red or maroon blood can indicate bleeding from the right colon or small intestine. Black, tarry, foul-smelling stool called melena indicates upper GI bleeding from the stomach or duodenum because the blood has been digested and chemically altered as it passes through your intestines. If you see black stool and it's not from iron supplements or Pepto-Bismol, you need to seek medical attention immediately that day because you could be bleeding from an ulcer, varices, or a tumor. Second, straining during bowel movements should not be normal. If you're regularly spending more than 5 to 10 minutes on the toilet, if you're holding your breath and pushing hard, if your face is turning red, if you feel exhausted after a bowel movement, something is wrong with your diet, your hydration, your medications, your motility, or your pelvic floor function, and you need to address it. Third, fatigue that's new or worsening needs investigation, especially if you're over 50, because anemia from chronic blood loss presents as tiredness, weakness, shortness of breath with exertion, pale skin, and people often dismiss it as aging or stress when it's actually a sign of ongoing bleeding. Fourth, any history of alcohol use, even moderate social drinking, warrants periodic liver function testing, especially as you age, because your liver's ability to regenerate declines and cumulative damage that seemed insignificant in your 30s and 40s can manifest as cirrhosis in your 60s and 70s. Fifth, abdominal pain, particularly upper abdominal pain, bloating, early satiety where you feel full after eating very little, nausea. These are non-specific symptoms, but in combination with rectal bleeding or a history of alcohol use, they could indicate serious pathology. Sixth, changes in bowel habits, new onset constipation or diarrhea, Changes in stool caliber where your stool becomes thin like a pencil. These warrant colonoscopy because they can indicate obstructing lesions. 7th, unintentional weight loss. If you're losing weight without trying, more than 5 or 10 pounds over a few months, that's a red flag for malignancy, malabsorption, or chronic disease, and you need comprehensive evaluation. Harold had at least 4 of these: rectal bleeding, excessive straining, fatigue, and a history of alcohol use. Any one of them should have prompted further workup. All 4 together should have set off alarms, but they didn't, because he minimized his symptoms. His doctor didn't dig deep enough, and everyone assumed the simplest explanation, hemorrhoids, when the reality was far more dangerous. Now let me tell you what you need to do to protect yourself, because this isn't just about avoiding Harold's fate. It's about understanding how your body works and treating it with the respect it deserves. First, if you see blood in your stool, on the toilet paper, or in the toilet bowl, do not assume it's hemorrhoids. Do not Google it and self-diagnose. Schedule an appointment with your primary care doctor or a gastroenterologist that week, not next month, that week. Describe the bleeding precisely: how much, what color, how often, what position you see it in, whether it's mixed with stool or separate, whether there's pain, whether there are other symptoms. Be prepared for a rectal exam, which is uncomfortable but necessary, and be prepared for the possibility of a colonoscopy, which is the gold standard for evaluating lower GI bleeding, and which can both diagnose and treat many conditions like polyps and some sources of bleeding. Second, never strain during bowel movements, and I mean never. The proper technique for having a bowel movement is this: sit on the toilet with your feet elevated on a small stool about 7 to 9 inches high, which puts your knees above your hips and straightens the anorectal angle, making elimination easier. Lean forward slightly, elbows on your knees, spine straight, breathe normally, do not hold your breath, and allow your abdominal muscles to relax. The urge to defecate should come naturally, you shouldn't have to force it, and the stool should pass with minimal effort, maybe a gentle push, nothing that makes you hold your breath or turns your face red. If you're straining, you're doing it wrong, and you need to fix the underlying problem, not power through it. Third, address constipation properly. This means eating 25 to 35 grams of fiber per day from fruits, vegetables, whole grains, legumes, not from a single fiber supplement, but from actual food. This means drinking at minimum 8 glasses of water daily, more if you exercise or live in a hot climate, because fiber without water makes constipation worse. This means getting regular physical activity, even just walking 30 minutes a day, because movement stimulates intestinal motility. This means establishing a consistent bowel routine, trying to go at the same time every day, ideally after breakfast when your gastrocolic reflex is strongest. This means avoiding medications that worsen constipation when possible, things like certain pain medications, iron supplements, calcium supplements, some blood pressure medications, antihistamines, and if you need these medications, talk to your doctor about strategies to counteract their constipating effects. Fourth, if you have any risk factors for liver disease, get screened. Risk factors include alcohol consumption, even moderate amounts like 2 drinks per day for men or 1 drink per day for women, especially sustained over years or decades. Obesity and metabolic syndrome, because fatty liver disease is now the leading cause of cirrhosis in the United States. Diabetes, which often coexists with fatty liver. History of viral hepatitis B or C, even if you were infected decades ago and didn't know it. Use of certain medications long-term, including some over-the-counter pain relievers. Family history of liver disease. History of blood transfusions before 1992, when hepatitis C screening became standard. History of IV drug use. Tattoos or piercings done in non-sterile conditions. Screening involves simple blood tests, liver function tests including ALT, AST, bilirubin, albumin, sometimes additional tests like a hepatitis panel, and if there's concern, an ultrasound or a fibroscan which uses sound waves to measure liver stiffness as a proxy for scarring. Fifth, Know the emergency warning signs that require immediate medical attention, meaning call 911 or go to the emergency room. Do not wait. These include vomiting blood, which can look like bright red blood or coffee grounds, black tarry stools that smell distinctly foul, large amounts of bright red blood from the rectum, more than a few tablespoons, severe abdominal pain, especially if it's sudden and intense, dizziness, lightheadedness, fainting, or feeling like you might pass out, rapid heartbeat, shortness of breath, chest pain, confusion or altered mental status, pale or clammy skin. Any of these symptoms could indicate active, significant bleeding, and you need emergency intervention, IV fluids, blood transfusions, endoscopy to find and stop the source, possibly surgery. Sixth, if you're over 50 and haven't had a colonoscopy, Schedule 1. The recommended screening age is now 45 for average risk individuals. Earlier, if you have risk factors like family history of colon cancer, inflammatory bowel disease, or certain genetic syndromes. A colonoscopy can detect and remove precancerous polyps, diagnose bleeding sources, identify inflammation, and potentially save your life. Yes, the prep is unpleasant. You have to drink a gallon of disgusting liquid and spend an evening on the toilet, but it's one day of inconvenience versus years of life, and the procedure itself is done under sedation so you won't remember it. Seventh, maintain a healthy relationship with your body and your doctor. This means not dismissing symptoms as normal aging when they're not normal. This means being honest about your alcohol use, your diet, your bathroom habits, your symptoms, even if you're embarrassed. This means asking questions when something doesn't make sense, seeking a second opinion if you're not satisfied with the first, advocating for yourself when you know something is wrong, even if initial testing doesn't show it. This means understanding that your body gives you warning signs, and ignoring them doesn't make the underlying problem go away. It just lets it progress until it becomes critical. Let me tell you what happened in the weeks after Harold's death. His wife, devastated and angry, wanted answers, wanted to know if this could have been prevented, and I sat with her for over an hour going through his medical records, explaining what we found at autopsy, talking about the missed opportunities. She told me Harold had complained of heartburn for years, took antacids daily, never mentioned it to his doctor because he thought everyone had heartburn. She told me he'd had spider angiomas, tiny red spider-like blood vessels on his chest and shoulders, that she'd noticed and asked about, but he said they were just age spots. She told me his abdomen had been getting slightly distended over the past year, that his pants didn't fit the same, but he'd joked about a beer belly even though he'd actually lost weight everywhere else. All of these, every single one, are signs of chronic liver disease, signs that his body was trying to tell him something was seriously wrong, and he either didn't know to pay attention or chose to ignore them because the truth was frightening. I've been a gastroenterologist for 18 years. I've seen thousands of patients. I've performed over 4,000 endoscopies and colonoscopies, and I can tell you with absolute certainty that the majority of serious GI conditions we diagnose could have been caught earlier if patients had sought care when symptoms first appeared, instead of waiting until they became unbearable or life-threatening. Colon cancer starts as a small polyp that takes 5 to 10 years to become invasive, and we can remove that polyp during a routine colonoscopy in about 30 seconds. Esophageal varices don't appear overnight. They develop gradually as liver disease progresses, and if we catch cirrhosis early, we can slow or even partially reverse the damage. We can monitor for varices and treat them before they rupture. Hemorrhoids are treatable with office procedures, dietary changes, topical medications. Rarely do they need surgery, but if you're straining hard enough to cause them, you're straining hard enough to cause other damage too. The protocol for healthy bowel function is simple but requires consistency. Wake up at a regular time, drink a glass of water, have breakfast with fiber, fruit, whole grains, maybe oatmeal with berries and nuts. Within 30 to 60 minutes, you'll likely feel the urge to defecate as your gastrocolic reflex kicks in. Go to the bathroom, use a footstool to elevate your feet, lean forward, relax, breathe normally, and allow the bowel movement to happen naturally. It should take no more than 5 to 10 minutes total, and you shouldn't feel strained or exhausted afterward. If you don't feel the urge, don't force it. Try again later or the next day. Your body will regulate itself if you give it the right conditions. Throughout the day, drink water consistently, not just when you're thirsty. Aim for clear or pale yellow urine as a sign of adequate hydration. Eat meals with vegetables, legumes, whole grains, fruits, healthy fats, lean proteins. Minimize processed foods, fast food, excessive red meat. Move your body, walk, stretch, exercise in whatever way you enjoy and can sustain. Go to bed at a reasonable hour, sleep 7 to 9 hours, wake up and repeat. This isn't complicated. It doesn't require expensive supplements or special equipment. It's basic human physiology, but modern life makes it easy to ignore. We eat quickly. We don't chew thoroughly. We choose convenience over nutrition. We sit all day. We're stressed. We don't drink enough water. We ignore our body's signals, and then we're surprised when things go wrong. Before you leave, I need you to do 4 things. First, hit the like button so this video reaches more people who need to hear it. Someone's life could literally depend on seeing this information. Second, subscribe to this channel because I post evidence-based digestive health content every week that could save your life or the life of someone you love. Third, share this video with anyone over 50, anyone with digestive symptoms, anyone who might be ignoring warning signs like Harold did. Fourth, comment below committing to one specific action you're taking based on what you learned, whether it's scheduling a colonoscopy, seeing a doctor about bleeding, changing your bathroom habits, or getting liver function tests. Those 4 actions take less than 2 minutes total, but could change everything. Do them now before you scroll to the next video and forget. Thank you for watching to the end. It means you care about your health. Now prove it by taking action.